Okay, well, good morning. I'm Jeff McLean. I'm a neurologist. I'm also the acting chief for Department of Medicine. Glad to be here to talk to you all about implicit bias or unconscious bias in healthcare this morning. You guys okay if I take my mask off from here? Make it a little easier. So I'm going to, hopefully this is an interactive, more of a conversation than just a lecture. I can and have done it more lecture style with minimal interaction, but it's less fun for me and probably less fun for you all. So the more participation and interaction, the better this goes. Feel free to jump in if you have questions, comments. I'm going to ask some questions too. Just in general, how many of you have heard about implicit bias or any formal courses or formal lectures on it previously? See some heads nodding. How many of you have taken the implicit association test personally? Just one, two, couple people, few people. How many have heard of the implicit association test? Not that many. Okay, good. All right, so normally I start off with a joke when I try to give this talk, but it's too early in the morning for me. You guys start very early. So most of you have probably heard at some point in your careers or have probably given advice to others about giving a talk in terms of how to start off a presentation. So I think most people have heard at some point that using humor is a good way to kick off a presentation. So if you look at multiple sources for how to give a good talk, from expert speakers, often they talk about using a sense of humor. If you look at the 11 public speaking tips from TED Talk speakers, number one is to use humor. And you can see here that this one in particular, I like, they talk about using self-deprecating humor to lower barriers. And the speaker that they reference, this Dr. Robinson, doesn't have a very dynamic physical presence. And so he's an academic. And so he has this perception that he's going to give a boring lecture. So he uses humor to make people feel more comfortable and more likely to listen to what he has to say. So I always feel like that one is applicable to me. So how many of you think this is good advice? Like, do you think it's a good idea to start off a presentation with humor, with a joke? Just show of hands, yes. How many people disagree? Anyone? Okay, so it's a pretty good way. It lowers barriers, gets people to feel comfortable with you as a speaker. Does it matter if you're a woman or a man? I hear some yeses from women. How about men? Do you think it matters? Maybe. Had anyone thought about it that's not a woman? So here's a study from Harvard Business Review from a couple years ago now, where they tried to look at this question and see if it makes a difference, how humor is perceived, whether the person using the humor is a man or a woman. So what they did was they started from the standpoint of that humor could be construed in a professional setting in two ways, either as functional or disruptive. And that people have different implicit or unconscious expectations of men and women, and that those unconscious or implicit expectations actually influence how we interpret those people's behavior. And so therefore, would people interpret humor differently based on whether the speaker is a woman or a man? So what they did is they set up the study. They got some actors to record videos of a retail store manager giving a presentation to regional managers. So they did 4 versions of the video, 2 each for the man and 2 each for the woman. Each of the actors recorded one version of the presentation with no humorous statements in it, just delivered the information straight. And then one version with 5 humorous statements inserted into it. And they controlled for everything else. So they gave resumes, and the resumes were identical other than the names. They gave other work history. The information presented was the same. The humorous statements were the same. Presumably they had relatively equal skill in delivering the humor, although that's hard to control for. And then they showed these videos to over 300 employees from various industries. And what they found was that with the humorous presentations, the woman's use of humor was consistently scored as both less functional and more disruptive, whereas the man had higher perceived status, higher performance, and leadership capability. Some of the comments that people gave in terms of the presentation were that for her, that she showed poor judgment in using jokes in this setting, and that she was trying to cover up a lack of knowledge or business acumen by making her jokes, whereas he was witty and he was using his humor so he didn't come across as too stern, and that he was breaking up the monotony of his presentation. So the same presentation, same content, same thing, the only difference being whether it was a man or a woman and perceived in very different ways. So relatively small study, but it gives us some insight. Why is this? Why does this happen? How many of you have seen this book or heard of this before, Thinking Fast and Slow? This is by Daniel Kahneman, a Nobel Prize laureate for economics. And he, in this book, Thinking Fast and Slow, talks about two systems of thinking, System 1 and System 2. System 1, or fast thinking, is our kind of quick, automatic, continuous, ongoing thinking that we do sort of in the background that doesn't require any effort, and is really based largely on intuition and our impulses. System 2 is really our more deliberate, effortful thinking when we're really focused on something, and stopping to think about it takes a lot more effort, takes a lot more control, takes a lot more time, and is therefore slower, but usually more reliable. So these two kinds of thinkings can lead us in different directions, right? So the issue with System 1, or fast thinking, is that it can lead us to do things that conflict with our conscious beliefs or intentions. So for instance, I have this issue fairly frequently come up. You all let me know if you've experienced something similar. So my wife and I switch off driving my son to school every morning. And so I have to go one way if I'm going to his school first and then coming to BAMC, and I have to go another way if I'm going to BAMC directly. And frequently, too frequently, I'm in the car with my son and I don't take the correct turn, and I come as if I'm going straight to BAMC, or the other way around. I don't have him in the car and I take the turn as if I'm going to his school. So I go the wrong way, even though consciously when I get in the car, I have every intention of going to one place. I end up driving in another direction because I'm using that System 1 fast thinking, unconsciously doing something that actually goes against my conscious beliefs. Have you guys experienced something like this before? It's a fairly common thing. I see heads shaking. So the whole point of this, and I will come back to this over and over again throughout this talk, is that the point of unconscious or implicit bias is that this automatic thinking sometimes leads us to do things that are explicitly against what we intend to do. And this is something that we're all at risk for because of the way our brains are wired and the way that we interact with our environments. And because we are physicians, because we operate in a world that's such high stake, in a field that's at such high stakes, our implicit biases have a very high risk of having a significant impact. And lastly, we're often taught to trust our instincts, but hopefully I can convince you that our instincts are often misleading and unfair. So here's some other examples of this from various fields, from various studies. And some of these you all have probably heard before in different versions. So this has been, the first one's been done several ways, several times, where they send out resumes, they have people review them to see whether they would give someone an interview based on the resume. Everything's the same in the resume, except for some of the resumes have a name that would typically be associated with a white person, and some of them have resumes that would typically be associated with a Black person. And the ones that are the identical resumes that are typically have names typically associated with a white person are 50% more likely to get selected for an interview based on that. And again, no other difference other than the name at the top of the resume. Another study looking at academics, hiring research faculty, lab managers, that when you control for quality, experience, all the factors that you would get from the resume, the men were consistently rated as both more competent and employable, and then men were selected for a higher starting salary and identified for more mentorship when compared to women with the same kind of experience background. Multiple studies have looked at, similar to the resume studies, CVs in academia, asking people to rate them in terms of quality, and women are consistently scored lower even with similar or identical backgrounds and experience. This last one I find interesting. This is from the legal field. What they did in this one was they took and generated a fictitious legal memo, and they deliberately in this memo put in 22 errors. So the memo has 22 errors in it. They gave it to law partners to review the memo. And the errors could be anything from analytical errors, spelling errors, factual errors. And when they gave it to the partners to review, the only difference in this memo was who was the author. And so when the author was listed as someone who happened to be African-American compared to someone who happened to be white, the law partners were much more likely to find those 22 errors. They found more of the errors consistently when the author was listed as Black. This I find interesting because I recently had a situation where one of our in our department specialists was questioned in terms of her technical competence, and her complication rate was being questioned, her competency was being questioned, and she did have some complications, she had some errors, but the question came up, and I think it's a reasonable question. I don't know the answer yet, but was she subject to this same kind of bias? Or is she at a higher level of scrutiny because she happens to be a woman, and in this case, she happens to be Black as well, than her colleagues who may also have similar errors, similar complications, but are not at the same level of scrutiny? I don't know the answer, but that's a question that was asked as I was reviewing the case and still looking into it. So those are all just some examples. And so let's just talk a little bit about, I think most of you know already, but what is unconscious or implicit bias? So these are associations, attitudes, preferences, assumptions that we all have, and we sort of learn and absorb from our environment growing up. We're typically unaware of these, that they exist, or at least where they came from. But despite the fact that they are unconscious, they can have a significant impact on our choices and our actions. In fact, many studies have shown that you can actually predict someone's behavior better by looking at their implicit or unconscious biases rather than their explicitly stated or conscious beliefs or values. This is important to note here again, that this is not the same as racism. This is different from explicit conscious discrimination against people based on race, gender, religion. This is unconscious and things that we absorb and that we're all vulnerable to. So this is not something that is, just white men. This is all of us. So for instance, in the study about humor in men and women, women also rated the women speakers as more disruptive and less functional based on their use of their humor. It wasn't just men that did that. Black people often have this same hold some of the same stereotypes that others do about Black people. So these things are very pervasive because of the society that and culture that we grow up in and that we absorb, and none of us are immune to this. And so it's something that we all have to be aware of, careful about. So what about medicine? So many of these examples, these aren't necessarily medicine. We all are highly educated. We all come into our field, I think, mostly because we want to help people. We want to treat patients. We want to make them better. So do we have this issue in medicine? So let me first ask you, do we in medicine primarily use system one thinking, that fast thinking, or system two thinking? And I will say I've given this talk many times now to medical professionals. I have not often spoken to just surgeons. So I usually make a joke about surgeons, but I'm gonna hold off on that one. But what do you all think? Do you typically use system one or system two thinking most frequently throughout your day? System one, so why? Yeah, so that's one great point, right? Is you system two takes more time and takes more effort. So how many of you at the end of most days say, oh, I've got all this extra time to stop and go think about what I did? I don't think probably most of you, especially in surgical training, have that extra time. So when people are stressed, when they're strained, the fallback is almost always going to be system one thinking. What about, so as surgeons, when you're operating, are you using more system one or system two thinking? Yeah. So I'm not a surgeon, so I don't know. I do procedural things within neurology. And I can tell you, it probably, in my experience, varies some based on the procedure and your level of training. When you're earlier and you're first doing a procedure, you're going to use more system two thinking as you're learning how to do it. But as you do a procedure over and over and over again, you're more likely, I think, in my experience, to stray into that system one thinking where you're doing things more based on your instinct, intuition, training, experience, rather than consciously thinking, okay, I need to do this, I need to do this, I need to do this. But it's more than that, right? It's more than just your actual procedural skills. What about your selection for who you operate on, who's a good case versus not a good case? How much of that could be impacted by system one thinking as well? And I think some of the studies throughout medicine argue that all of these things are areas where we as a profession actually do fall short. So this is one systematic review that was done in published in 2017, where they were looking for implicit bias in healthcare professionals. So what they did was they, based on their inclusion criteria, they selected 42 articles. And of those 42 articles, 35 of them, these were articles that were doing studies that were looking for evidence of implicit bias. And of the 42 that were performed, 35 were positive in terms of demonstrating evidence of implicit bias in healthcare professionals, most often based on race, ethnicity, gender, age, and weight, although there were some others like religion, socioeconomic status that were also included. Not all of the studies looked at the correlation with the quality of care, but those that did look at the correlation with quality of care demonstrated that as the levels of implicit bias rose, the quality of care declined. One example of this was a study from 2007 where they actually looked at emergency medicine and internal medicine residents at 4 different academic centers. And what they were looking at was the decision to administer thrombolytics for acute coronary syndrome. And so of these residents, none of them endorsed an explicit or conscious preference for white versus Black patients. And they only looked at white versus Black because that was based on where they were geographically, that was the vast majority of their patients. So although there was no conscious or explicit bias noted by any of the residents, they did do the implicit association test. I'll talk a little bit more about that towards the end, but it's a way of, for those of you that aren't familiar with it, it's a quick test that you can take that can potentially give some insight into whether you have some unconscious biases based on race, based on gender, based on a variety of factors. And what they found based on the implicit association test was that there was an implicit preference for white Americans over Black Americans in these residents, and specifically that Blacks were less likely to be cooperative in general, and that Blacks were less likely to be cooperative specifically with medical procedures. And so they found these implicit beliefs in this group. And what they noted was that as these implicit biases increased, that the likelihood of those physicians choosing to give thrombolytics to the Black patients decreased. So it actually did impact the choices they made in these clinical vignettes in terms of how they would treat their patients. And, you know, you can't necessarily prove the causation, but we see this borne out in multiple looks at disparities in care, whether you're talking about acute coronary syndrome in my field and stroke and various other scenarios consistently. In fact, there was another study, just to give you an example, that looked at this, and they actually compared from 1994 to 2002, looking to see if this trend changed over time. They were looking at rates of reperfusion therapy. And the way that it went was that white men were most likely to get reperfusion therapy. And then after that, it steadily declined for sequentially white women, and then Black men, and then Black women. And that was not improved from 1994 to 2002, that trend continued. And that, why exactly that is, can't prove why, but I would argue that a lot of that has to do with implicit or unconscious bias in terms of how people are choosing who are the right candidates for reperfusion therapy. Same thing happens in multiple other examples. Here are some examples from my field, from neurology. The specifics aren't so important here, but the points that I like to make are that it crosses across my field. This is several different subspecialty areas within my field. And I think the same could be done in just about any field, where the more you look for these disparities in care, the more you find them. And the other thing is that these are fairly recent and span time. So one of the points that I was trying to make with my last example, you know, the study looked at, and they compared 1994 through 2002, and didn't see any change, is often people wonder, well, is this problem getting better on its own, right? As our profession and as our population becomes more diverse, are we doing a better job with this? And the answer is it doesn't really look like it's getting better on its own. These disparities that we see in terms of care, access to care, outcomes, are fairly persistent. And the more studies that are done looking for them, the more we find them in fields all over. The other thing that I like to point out here, in addition to the fact that it's not necessarily getting better over time on its own, and the fact that it's very pervasive across multiple areas, is the second to last one here is about multiple sclerosis research into therapeutic agents. And what these studies actually looked at was the patients that were enrolled in the trials that define treatment therapy. So obviously, you all are probably not doing a lot of multiple sclerosis treatment, so this may not be in particular relevant to you, but the point that I'm trying to make here is that what this trial showed is that our studies that help define how we should treat multiple sclerosis underrepresented groups that are already underrepresented in our population. And so they are already biased potentially against certain groups. And so even when we use what we believe to be the best available science and evidence to drive our care, that evidence may be biased against certain people. Another example of this that a dermatology resident pointed out to me that I thought was a good example is if you think about, your dermatology textbook from medical school, how many of the images in there are of people with darker skin? Not many of them, right? Most of them were from white patients. And obviously that has an impact on how you interpret dermatologic issues. And so even in the training that we get, there are biases baked in and built into those that we may not even be thinking about, but may impact how we care for our patients. So there's many examples of this, and some that are more relevant to you all have to do. So for instance, how many of you have heard about studies looking at how pain medications are prescribed to patients based on gender and race? Have you all heard or seen anything like that before? I see a couple heads nodding. Anyone want to talk about what they've seen or heard about? No one wants to volunteer. This is the example of me talking and talking and talking without the interaction. So okay. So what they've looked at is that first of all, there are implicit beliefs in medical providers that, and this has been shown in multiple studies, that Black people are less sensitive to pain. So there are people, and they've done this in medical students and residents and physicians, attending physicians, and there is an increased belief that Black people are less sensitive to pain. So if you start there and you think about that people have this belief, physicians who are prescribing medications, then it's not such a stretch to imagine that when treating either post-traumatic or post-surgical pain, that people may not treat Black people the same as they treat their white counterparts, even with the same types of injuries or the same types of surgeries. And in fact, that's been shown in multiple studies that when you look at prescribing patterns, that Black patients with the same type of injuries as their white counterparts consistently receive less pain medication post-trauma and post-surgery. Does that make sense? And that's been consistently shown. Does anyone believe that the majority of that is related to anyone explicitly saying, I'm going to do a worse job treating my Black patients than my white patients? I don't think so. I don't think many, if very few, get into medicine with that kind of thinking or that kind of belief. But again, our unconscious beliefs when we're making decisions, when we're busy, when we're stressed, when we're not stopping to really think, sometimes we incorporate these things into our thoughts and decisions that we're not realizing, and it can have a significant impact. I'll give you an example that we have seen here at BAMC, because often people think military medicine is immune to these disparities in care, right? Because we have basically everyone in our system has full access. We have a relatively better educated population than most places. We don't have as much of the same socioeconomic issues as other healthcare systems. So a lot of times people assume, well, that kind of gets rid of the disparities. Again, more and more studies are showing that that's not true. I'll give you a small example from our department. We looked at this over several years, looking at our code strokes and times to give TPA for code stroke. And what we've seen in our own practice is that it takes women patients consistently longer to get TPA than it takes men. So why might that be? Why would it take, and our study doesn't, I can't tell you exactly why. I can tell you why I think it is, but why do you all think that might be? Why does it take us longer to give TPA to women than it takes us to give TPA to men? Yeah, so could everyone hear that it takes longer to recognize that women are having a stroke? I think that's a large part of it. What else is? So good question. So how did we measure it? We looked at both door to needle time and also our time from the actual neurologist evaluating the patient to needle time. So, and both were prolonged for women. So we wanted to subtract out as much as we could of other people and actually look at our department, and in both cases, women had longer times to get TPA. Any other thoughts about why this may be? So I think the majority of it is that it takes people generally longer to recognize that this is a stroke when the patient is a woman. I think there is an unconscious or implicit expectation that sometimes we take symptoms in women less seriously or less urgently than we do in men. This has also been shown for acute coronary syndrome, right, where consistently women are not taken as seriously, especially with atypical presentations of chest pain or acute coronary syndrome. People are more likely to believe that women have psychogenic presentations than organic presentations for an underlying etiology for any given presentation. So in general, it takes more time to get to these more definitive invasive therapies. So these are all things that are very present today in our institution. I suspect if you look for these things, you'll probably find them in your own care, because as I say, these issues are really pervasive and ubiquitous. And if you're not looking for them, it's really hard to realize they're there or the impact that they can have. I also think it's worth mentioning how much of an impact these have from a professional standpoint. We've talked a lot about the healthcare delivery standpoint, but from a professional standpoint, how does this impact our profession? So there are a lot of biases that can come into and impact our profession and how we interact with one another and how people progress through our field. So when you think about, for instance, if you look at data from the AAMC, and they track people in academics and they track demographics and everything. And so they look at the numbers of people in academic institutions by academic rank. This is just one simple way to look at it, and they break it down by gender and race. And so obviously we have people and groups that are underrepresented in medicine. Are women underrepresented in medicine? I'm sorry. Yeah. So it depends on what level you're looking at. In terms of just overall numbers, if you look at medical students, women outnumber men now in medical school. And in the profession overall, men slightly outnumber women overall, but that is changing. And the the difference isn't very big. When you look at senior levels of medicine, is there a difference there? A huge one, right? I mean, it's very uncommon that women are in senior academic and medical leadership roles. The disparity there is big, despite the fact that women have been in increasing numbers in the field of medicine for decades. So just increasing the diversity from a gender standpoint has not resulted in the appropriate or expected increased level in higher levels of leadership. And why is that? Does anyone believe that women are less capable or less ready for those positions? Or are there things that are actually impeding women's progress in getting into those positions? And so I don't think, well, there is some explicit and intentional bias against women, but I don't think that's the majority of it. I think a lot of it is unconscious. So for example, there's something called affinity bias. Has anyone heard of this term before? Anyone know what that is? So this is something that is often people will talk about and not necessarily think about it as a negative thing. So this is when someone who's in a leadership position says, I really like this person. They remind me of me when I was at that stage of the career, right? So anything wrong with that? I see some no's. Right. So if all the senior people happen to be white men and they're all saying, I like people that remind me of me, who's going to get chosen for leadership positions? More white men. So it's not that you're necessarily thinking I'm going to discriminate against women or people of color. It's just that you tend to identify with people that remind you of yourself. And if all the people who are in power are a certain group of people, they're more likely to recruit and mentor and promote and advance people who remind them of themselves. So that's one type of bias, affinity bias, that can be, very, very powerful and not something that people tend to think of as an issue. Another example is what's sometimes called a benign bias. So this is one actually that I realized that I was doing several years ago, and it wasn't until I went to a talk about bias that I really started to think about this. So this is the idea being that when I was a program director before, and I was working with residents, and when I was looking for opportunities and to promote residents and giving them opportunities to lead, I would often, for my male residents, just give them the opportunity or say, hey, you should do this. For my women residents, I would often think about, well, I don't know, she's got a family, she just had a kid a couple years ago, this might be asking too much of her. I don't want to throw too much on her plate. And I thought I was being considerate, but what happens if you carry that trend out over time is the men have children too, the men have families too. So why am I just giving the opportunities to the men and I'm hesitating in terms of giving those same opportunities to the women? That over time leads to the same problem where men are disproportionately getting opportunities that women are not getting. And I thought I was doing a good thing. And in fact, I was not. And, it's the answer to that is fairly simple. And, it took one of my women colleagues giving this talk for me to really realize a very simple answer is don't assume for the women, just ask them, give them the opportunity to tell you. If they don't want to do it or if they can't do it, they can tell you, but don't not give them that opportunity because you're thinking you're doing them a favor. So that's another example. Other things I've heard multiple people, unfortunately, in program academic leadership talk about when selecting residents, and I'm, this is not from the 1950s, this is in the last decade, make comments like, well, if everything else is equal, it's safer for me to take a male resident than a female resident because the female resident may get pregnant and then it's going to disrupt the program. Does that shock anyone in this room to hear that? So these kind of things still exist and they still happen in our profession, and people that I think are generally fair-minded, but people say that and are not thinking even what the impact of that is and what that means to people in their careers and their opportunities. We consistently see women in academic and practice settings have significant pay differences compared to their male counterparts. Neurology is actually, this came out about 4 years ago, where they looked at this by specialty. Neurology actually happens to be one of the worst fields for gender pay equity. But it's fairly consistent across multiple fields within medicine that women at the same level for doing the same job get paid less than their male counterparts. Why is that? So even once you get into medicine, even once you get into more senior positions, even once you advance up the chain, women are getting paid less than men. Why is that?
Part of it's bias, but also part of it's
Yeah, and so there's multiple components to probably why that is, like you said. So women, I think there's some opportunities to intervene on that in terms of mentorship and giving women, especially, the skills and the space to be able to negotiate and push for themselves. But also what happens is, and if you talk to, again, many of the men who are making decisions about this, they're making comments about, well, she's more likely to, be less productive because she has a family. I'm concerned that if we put all this investment into a woman who may be out for either maternity leave or for whatever other cause, so I'm less likely to put that much investment into a woman. And these are things that people are still saying to this day. So those are just several examples that I think are good for us to think about, that in our profession, in our field, even today, we're still seeing. And so I think it's really important, again, to think about these things. So I've talked a lot about, these biases existing, but what can we do about it? So there's less evidence for this. There's a lot of and increasing evidence, as I've mentioned, about the presence of biases. There's more and more about, specifically in healthcare, and how those biases may impact and lead to some of the disparities in terms of care. As far as how we can intervene, that's less clear. So there's some ideas that aren't necessarily evidence-based, but I think they make sense. And I think the first and most important one is to look for our own blind spots and look for our own biases, because we all have these. None of us are immune to these, and we're in such important and powerful positions. And maybe as an intern or resident, it doesn't always feel that way, but think about the power and the influence and the decisions that you make on a day-to-day basis, that you may not even be realizing how important and how impactful those decisions are for your patients. I think we have a much higher obligation to look for these blind spots and how they could be impacting how we care for our patients. So I would encourage all of you to take some time to complete these implicit association tests. So it takes about 10 minutes or so to do one. They have different ones. My last slide is a link to it also. I'll give you all the link to where, and this is done out of Harvard, that they've done this, and they've done thousands upon thousands upon thousands of these tests. And the idea is what they do is they take the idea that if you have these implicit or unconscious biases, that it's easier for you to associate certain words or certain ideas with certain types of people. And so what they do is they give you a test, and it's timed in terms of how you can associate images of certain people with certain words. And so the idea being is that if you are more likely to, for instance, have positive associations with white people and negative associations with Black people, you'll more quickly be able to associate those positive words with images of white people, and more, it'll take you longer to associate those positive words with Black people. Does that make sense? Similarly, they have one, for instance, about gender and career. So what they find is that across the population, both women and men consistently have a harder time associating career, a career type words, phrases, and ideas with women than they do with men, and they can consistently associate family related words and ideas more quickly with women than they can with men. Does that make sense? So they're looking for how easily our brains can apply these ideas to different kinds of people. And again, they do this by race, by gender, by weight, religion. There's different ways to look at it. And I would, highly encourage you to take some time to do this. There are certainly some potential flaws with implicit association tests. The test retest reliability has been called into question. There are certainly things that can impact a score, but I think the point is that this is one of the best ways that we have available to us, although not perfect, to look for potential blind spots that we may have. And if you can do this, and you can walk away, with 10 minutes of taking one of these tests, and you can walk away from that and say, okay, maybe I have some biases against a certain group of people. And then in your interactions with patients from that group, take a couple minutes at the end of your encounter to say, am I allowing these potential blind spots to impact the decisions I'm making for these patients? So if I have a bias against women, or if I have a bias against Black patients, take a couple minutes to force yourself into that system to thinking, to really stop and think about what assumptions might I be making that might be influencing the decisions that I'm making for this patient. I think that can be really valuable. Trying to really combat and push your mind from stereotyping people and trying to actually get information about patients. So for instance, people have a tendency to associate Black people with, as I said before, lower rates of cooperation, specifically with medical procedures, less ability to be compliant with complex medical regimens, right? So people might assume, well, this might be the way I would normally treat this, but I don't think this patient is a good candidate for this. They need something more simple, more straightforward that they're going to be compliant with it. Does that sound like something that's feasible? Does that make sense? That's something that we see, at least for epilepsy therapy. You may see it for hypertensive therapy. I would imagine that also, I know that can happen in terms of selection for patients for surgical procedures. So instead of assuming that about a patient, actually assess what is their educational level, assess what is their ability to be compliant with whatever regimen or therapy or procedure or post-procedural instructions, instead of making unconscious assumptions that may impact your selection of patients. Trying to put yourself in your patient's shoes, and that sounds kind of cliche, but just thinking about, if I were this patient with this presentation, what would I want, or what would I expect? And just think about, if that's different from what you're offering them, why is that? What is the reason for that difference? And sometimes there may be a good reason, but sometimes maybe there's something unconsciously that you're doing that's impacting that decision. that you may not be aware of. And so trying to put yourself in their shoes can help identify that. So all of these things get to really trying to force yourself to be aware of your blind spots, to be aware where you may be missing something, and try to force yourself to think consciously instead of thinking fast that can create those errors. This is the link for the IATs, or the implicit association test. Like I said, I would highly encourage you to take 10 minutes to do one, do a couple. I've had people tell me, well, I took it multiple times until my bias went away. Doesn't work like that. That's probably not the way to do it. This is a tool, no one else gets this information. It's just a tool for self-assessment to try to find where you may have a blind spot. So I'll stop there. I think we have just about 10 minutes left for comments, questions,